Can I please begin by acknowledging the traditional owners of the ancestral lands upon which we meet today, the Whadjuk people of the Noongar Nation, and pay our respect to their elders past and present. We have the Honourable Darren West to my right, the Deputy Chair, the Honourable Colin de Grassa, the Advisory Officer Laura Hutchinson. To my left, we have the Honourable Wilson Tucker and also the Honourable Sandra Carr. Thank you very much for coming. Before we begin, could you please state your full name and capacity in which you appear before the committee today?
So my name is Dr. Bruce Powell, and I'm appearing as the former State Medical Director of Donate Life in WA.
Thank you very much. And I'll require you to take either the oath or affirmation.
Certainly. I swear by Almighty God that the evidence I will give before this committee will be the truth, the whole truth, and nothing but the truth.
You have signed a document entitled Information for Witnesses. Did you read and understand that document?
I did, yes.
These proceedings will be recorded by Hansard. A transcript of your evidence will be provided to you after the hearing. Please note that this broadcast will be made available for viewing online after this hearing. Please advise the committee if you object to the broadcast being made available this way.
I have no problem, thank you.
To assist the committee, please quote the full title of any document you refer to during the course of this hearing for the record. Please be aware of the microphones and try to speak into them. Make sure you do not cover the microphone with paper or make noise near them. If you make adverse allegation during your evidence, the committee may release that information to allow the other party a chance to respond. I remind you that your transcript will be made public. If you wish to make a confidential statement during today's proceeding, you should ask the committee if you can give your evidence in private. If the committee grants your request, any public and media in attendance will be asked to leave the room until the transcript of your public evidence is finalized. You should not make it public. Advise that publication or disclosure of the uncorrected transcript or evidence may constitute a contempt of Parliament and may mean that the material published or disclosed is not protected by parliamentary privilege. Would you like to make an opening statement to the committee?
I think I would just say that for me, organ donation remains a profound, extraordinary demonstration of community. And so when I speak to community, when I speak to my role, the medical role, the political role, the financial role, I'm always mindful that all of us are facilitators to a process that absolutely relies on the faith and the trust of the community, which is where the donations come from. And therefore, I'm always very mindful to make sure that any conversations we have are not ones that bring into doubt the very sort of nature of the process and the trustworthiness and the effectiveness of that process. And I think it's very important for all of us to remember that when we talk about it, is that it is a highly sensitive subject. I mean, when I spoke at the Transplant Games, I said that, there's part of me that always remembers that when we, as it were, celebrate the number of donors, for example, we have to remember that each one of those donors represents a tragic loss, and we have to always make sure that we bear that in mind when we talk about these topics. Thank you.
Thank you very much, Dr. Powell. I would like to ask, can you please give an overview about your background and your experience in the space of organ and tissue donation, please?
Certainly. So I was obviously qualified in the United Kingdom as a medical doctor, and then had 6 years in the Royal Navy, and then after a time in medicine, became a nephrologist, which is a kidney specialist. And so I spent some time at 4 years at the Sheffield Kidney Institute, and that introduced me to organ donation as a topic. And so I spent 4 years on the other side of that. In other words, the managing of people with kidney failure, and again managing those who've had transplantation. Mm-hmm. When as part of my journey, I became then an intensive care specialist and an anaesthetist, which we don't have time to explain how that happened. But when I came here as an anaesthetist, and ultimately became the person responsible for opening the intensive care unit at Rockingham. So Rockingham was the first non-tertiary intensive care unit to open in WA, which obviously for someone like myself from the UK was a remarkable opportunity and an exciting one, although I'm sure many would agree that you do learn some leadership skills on the way that you might not have had as a junior. And when I got to, once the Rockingham intensive care unit was up, my question was, well, are we going to do organ retrieval? Obviously, it was a topic that was close to my heart. Now, you know, for many reasons, the culture in WA is that organ retrieval, organ donation, is a tertiary procedure. In other words, when I say tertiary, I mean specialist, and those sort of activities would always centre around Charlie's and Royal Perth. That was how it was. Nothing wrong with that. It's intensive care is highly intensive, and you need to keep your resources close to you. But actually, the retrieval of organs is, and I'm glad there are no surgeons in the room to argue, but it is a relatively simple procedure. And in fact, the implantation and the further management is much more complicated. And given that exclusively organ donation patients come from intensive care units, once Rockingham had an intensive care unit, it was a natural extension to say, well, we'd like to be involved. And interestingly, and typically, coincidentally, organ donation, Donate Life in WA had not had a leader for, I think, around 9 months. And someone once said to me, and I think it reflects part of the culture, someone said to me, well, you're going to join the dark side. In other words, the clinician and the administrator, there's a certain gap between the two. And I'm no doubt that others have made some comments upon that. But for me, as it were, an outsider, where my intensive care qualifications are not recognised here, the irony, of course, was that I wasn't able to work at Royal Perth or Charlie's, but I was able to open a unit and be the head of department 40 kilometres down the road. And maybe that's a good thing, because I came with a kind of different attitude that, all the intensive care units I'd worked at, we swapped patients, we swapped information, we shared a lot. And that was one of the things to learn here, was that, even as an intensive care unit that was new, you were pretty much isolated. And I suspect that most of the intensivists in town didn't even know there was an intensive care unit at Rockingham. However, it wasn't very long after that Donate Life came to me and said, I don't suppose you'd be interested in being the head of Donate Life in WA. You're the one kind of unsolicited by them. You're the one saying, hey, we should do this. And actually, I think that was, a refreshing kind of change. There's someone out of town who perhaps doesn't understand quite how things are, that actually, and could not really leave to work in the sort of ivory towers in Perth, that actually, again, organ donation leadership was another remarkable opportunity for someone who, frankly, really, apart from clinical experience, had no real right to lead a service. And so...
And sorry, which year was this?
So this was, I think, 2000, and I started at Rockingham, I think, 2008, 9, and I'd have to check those. And I became head of organ donation in about 2012. So that wasn't long after the government had made sort of bold, investments and decisions around bringing some structure to organ donation. And obviously, I'm always very mindful, having been on both sides, that financial investment in a controversial and difficult topic always leaves one vulnerable from both sides to criticism of either how it's gone, how it was set up. And so I was always very mindful to keep those conversations behind closed doors. I think it's I think all of us, when we talk about organ donation, you have to wear the T-shirt and you have to reassure people that you're committed and that you have them at your best interest. Now, I don't need to tell this committee, I don't think that when you close the doors, by all means, those conversations can be a little bit more frank and a bit more direct about the good and the bad. But I think it's very important for the community to see that although we may disagree about the how and the why and the what we don't disagree on is that it's very important for the community. And so, I became head of Donate Life, and they're a remarkable group. And as I said, I spent 2 years probably trying to understand how it was before I tried to do anything about it. And that was the first bit of wisdom I think I learned from Donate Life and from leadership, was that it was best to shut up and listen when you didn't really understand what the challenges were, both for the community, both for the NGOs, for the surgeons, for the intensivists. Again, organ donation happens through collaboration. And if any part of that doesn't work, it's very difficult. And that's, of course, the most difficult part of any system that's complex like that, is everybody has to be on board. Otherwise, it simply doesn't work. And so, over the years, I think we went from 13 or 14 to 54, I think, in 5 years. And again, that is a combination of engagement by the community, intensive care units, really kind of stepping up their game, and every other part of it, pulling, doing their work. And as I said, I'm very proud of that success. And I think, I think I've made the point in my submission that when we talk about donors per million, which is the KPI, the target that we use, which again is not necessarily helpful. It's very important to remember that if you take that organ donation can only happen in intensive care units, 25% of WA's population live more than 1,000 kilometres from an intensive care unit. So if you took that metric and took the denominator rather than the total population, if you took it as 75%, actually we're pretty damn good. And again, that's not to be complacent about it, but it is to try to avoid a bit of that interstate sort of competition about who does it better. Again, you know that WA is a unique place geographically and maybe even culturally, and I think it's not always helpful to be competitive. There seems to be an innate response from Australians, God bless us, that we want to be competitive. I think the problem is that that's not always a particularly helpful thing. It can alter, again, the public's perception as to who's doing better and who's doing worse. So again, I think the great thing about Donate Life, about Canberra, about Lucinda and Helen who are here, is what they've done is they've insisted that they talk about the data. I used to talk about the film Hidden Figures, where you have a group of people nobody really knows, but they work out the numbers. So if you want to know the numbers, you ask them. If you want someone to do a press conference, you ask Neil Armstrong, because I gather he was a good pilot, but he's a good-looking fella and he fits the narrative. But the people doing the work behind the scenes have the data. Don't get involved in the controversy and some of the opinions. Merely be the ones who provide the facts. And so one of the facts that I'm sure that Lucinda and Helen talked about is that we know that conversations around donation that include donation specialists, we know that the success rate of those is 80%. Now that varies between states. Tasmania has an extraordinary record. And if you don't include those specialists, the consent rate is 50%. Now, that's not to characterise necessarily why that is, but it is to acknowledge that in Australia and internationally recognised, as Spain demonstrated, that if you allow people with a particular skill in the conversation around donation, if you allow them into your place, don't get me wrong, intensive care is a deeply committed group of people, highly skilled. It's not that easy to invite other people in, particularly when you think about, most intensive care patients where there's been a long struggle. We come to know the relatives, we come to know them personally, and that's part of the process, and it's a painful one, giving a little bit of yourself. And so when you're then told, well, actually, the evidence is that you should invite these people in to talk about end-of-life care and talk about organ donation, that's a really difficult thing to do. And as I said, I have the luxury of not being in that space now, not being in medicine, not being being in charge of organ donation. And so I'm able to say that I think one of the significant barriers is what is also a strength in WA. As I said, these are highly skilled groups, world-class results in terms of in terms of critical care. And yet when you look at the numbers around invitations into donor conversations and outcomes from those consents, we're not as good as some. We're okay, but we're not as good as I think we'd like to be. And I think that's a reasonable aspiration. I think it's reasonable to look at the Spanish and say, well, look what they do. And I don't forget that, of course, the Spanish changed to opt out, which obviously is one of the issues. They changed to opt out 10 years after they instigated a revolution in terms of outside specialists coming in, collaboration, working together. So actually, when they agreed to opt out, nobody really noticed. And in fact, they don't even have a right of appeal when they take the organs, because they don't need to. And actually, my experience in WA over the years of perhaps, maybe 4 or 5 unfortunate tragic stories where people lost their lives here from Europe, it wasn't unusual to be wrong to say, so are they going to be an organ donor? In other words, culturally, that was what happened. And as I said before, culture is what happens when behind closed doors. Culture is a thing that happens in private when no one's there. And that culture of, well, will they be an organ donor? It's just a natural reaction. So the Spanish are mystified by our slight struggles to get the doctors and the Donate Life and the community together, because the Spanish kind of go, well, we've been doing that for 30 years. Now, dare I say again, or a strength and possibly a weakness in Australia is we like to do it our way. We like to be, we've forged a proud history of going our own way. And do you know what? Yeah, okay, Spain, but we're not like Spain, and we're not like Spain. I always like, there's a nice example when people talk about the randomness of this world, that unless you start off with exactly the same starting conditions, even if you do exactly the same thing as they did, it doesn't mean you'll get the same outcome. And I think, although we can take some advice from the Spanish about how they did it, we still have to find our way. And it may be that within the States, we have to find slightly different ways. But what we know from the external authority is that one of the proven ways, wherever you are, is to involve external specialists, nursing staff, into the room, into that conversation, because that has families say yes.
Now, Bruce, perhaps I can just follow up on that.
Sure.
In terms of the Spain's similarities or differences between that country and us. You would agree that there are more similarities between the UK and Australia compared to that, comparison between Spain and Australia. Now, as we know that all 4 jurisdictions have moved to the opt-out model in the UK.
Yeah.
And what's your view on the gradual transition in the UK? And do you see any benefits for Australia to look at that?
Look, I understand the motivation. Again, the great thing is we're all agreeing that we're hoping to get have more donors. If people reach to that point where donation is possible, we'd like to see more of those people benefit from transplantation. We also know that, as I said, that the Spanish success is not predicated upon opt-out. And I think, some of the evidence, for example, from the Welsh, is that it doesn't necessarily create a sort of avalanche of. And I don't think anybody's suggesting that Australia will take organs without consenting family. It's just not how it works. And I said this to people before. Do you really want a grieving mother, sort of who chains herself to her son? Do you really want that person cut away and dragged off? I mean, clearly we don't. And from that, I would say to you that I think that opt-out, once you have people on board, once you've got not 35% of people signed on the organ donation register, but 80%, maybe then it's reasonable to assume that people kind of know and just didn't get around to it. And therefore, maybe opt-out is a sort of thing where people don't kind of want to talk about it, but I know about it, and, the sort of yuck thing. I think if you're only at the levels we're at, for me, the authorities and people like myself still have a responsibility to share that information, to make sure that people really understand and that they're not afraid. I mean, I used to say very strongly to people that if you don't want to be a donor, you should tell the authorities, because the last thing Donate Life and intensivists want to do is retrieve organs from someone who didn't want that. So what we're actually saying is that our drive and our commitment, I think, as a community, is that everybody who wants to be a donor and can be a donor should be a donor. It's as simple as that. And if you don't want to be a donor, that's fine. And if your relatives know what you want, they agree. And I know people quote 90%. Well, that 10% will include extraordinary circumstances where, frankly, nobody could expect anybody to possibly agree. And we also know that, we went through, when I was the leader, we went through a long sort of difficult change of where you could register. As I'm sure you know, the organ donor register used to be held by South Australia on a sort of spreadsheet, which then didn't translate very well into the back end of some other software thing, which is now the organ donor register, which, look, even at my age, I kind of understood sounded really bad. So now we've got the electronic register, 5 minutes and you can do it. And, we've seen a lot more people register. But again, personally, I would be loath to, assume that opt-out would be a revelation in terms of numbers. And as I said, I would take, tiresome as it is, the Spanish view that, well, everybody agreed anyway. And I don't think we can say that. We've seen, you often hear Donate Life quote the study that said that 85% of people agree with donation. If you look at, God bless the marketing company, if you look at the question that was asked, it was, are you supportive of the notion of donation? Not, are you happy to give your organs if it comes down to it? So again, we draw out this sort of everyone's in for it. Well, maybe they're not, and if they're not, well, let's keep working at that, And I know that's difficult, and it's time consuming, and it's potentially costly, but I'm not saying that it would be wrong to opt out. And in many ways, you might argue that the opt-out conversation and the opt-out process would in itself raise the stakes. And I suspect that might be Helen and Lucinda's view, is that actually the conversation around, hey, everybody, we're thinking of changing this, would in itself spark a conversation that, again, I don't think it's not a political thing. It's just a thing that we know from the data. I will finish, I promise, is that families are glad that they were asked, not at the time, but they're overwhelmingly glad they were asked, and glad that their relatives became a donor. And make no mistake, it's not a consolation. It's not a consolation for the loss they've suffered, but somewhere down the line, a long way down the line, and like as the donors that I met at City Beach, at the sculptures there, they're proud about that and they're glad about that. Could they, if they could turn it around, of course they would. But they can't. And so, it's a good thing. And as I said at the very beginning, I think it's a remarkable demonstration of humanity, and I like that.
Before I go to Sandra, Bruce, you talked about this opt-out, model may not be the avalanche. Did you follow the development in the UK since around the time Wales was debating to move to the opt-out model?
A little bit. I mean, I had some conversations with some of the leaders there, and I think they were convinced that it was a very, don't get me wrong, of course, it's a very soft opt-out. Mm-hmm. So nobody's just walking in and taking organs. Families are by definition part of it. And I suspect that if anybody fervently didn't want to, I think they would respect that. So it's not a tool to sort of ram open the door. I think again, it's more an expression of a kind of shared aspiration that, okay, maybe we don't want to talk about it, but so I'm aware that there was some controversy, and I think, as I said, it's very important not to politicise it. And I know that's not what this committee is doing; it's seeking to get some clarity, and I think that's one of the things to avoid. It's not about who did it better, because again, the community are looking to us to be reassured that so everybody's on board with this. And I think if they are, then, as I said, when people express their views, occasionally we would find that organ donor families wouldn't know that their relative was on the register. But a phrase that always stuck with me was that when we told families, they would often say, that's the kind of person she was, that's the kind of person he was. And I used to like that, because that kind of, to me, echoed a little bit of people kind of with a sort of resigned tone, sort of saying, yeah, and it's sad, isn't it? But they were a kind of a generous person. I used to, again, organ donation were a bit reluctant for me to say it, but the only person who doesn't benefit from registering is the person who does it. Because the one thing that you will do is you will get nothing out of it, but it does say something about you. And I quite like that. I think, it's not a selfish act to put your name on the register, but it does kind of say that you perhaps have a sense of community and a sense of togetherness. And I always figure that Western Australia, that kind of suits us. I think it suits us to say we're all in this together, even if that means we're not all in it with that lot. Well, actually, all we're saying is Western Australia benefits from our community being generous, and if there are other organs to be had, then we now have systems to share with the East Coast, and that's a wonderful thing. And as I said, it sounds a bit sort of a little bit touchy-feely, but it does come down to that, and I think it's very important to remember that.
Thank you, Bruce.
Okay, thank you.
Sandra.
You just talked about the Spanish experience, and so their long history of donation specialists, I guess, is whatever their model of that is.
Yeah.
And then having transitioned to the opt-out model. What was their rationale for doing that from your perspective, in that they've already had these effective practices and then went that direction?
That's a good question. In fact, I've spoken to the lady who used to lead their organisation.
If we have time.
I'm not sure. I think it was a more a legislative drive, because actually they saw a certain little bit of dip when they actually moved where they were based. There was a certain disruption to the whole system. In other words, it's like an ecosystem. And when they changed the system that was very successful, they actually saw a small drop in what they were doing, and then an acceleration. So again, it was that collaborative, shared experience, specialists in hospitals, talking to any number of specialists. And of course, then you've got junior doctors, junior nurses being okay with it. So it's not a taboo topic. It becomes just something that we do, and I think, as we know, that sort of culture is very difficult to create, and it's very hard. It's very easy to lose, So I think, again, they don't have those terrible occasions. As in the United States, they have a bit more of a sort of mandated, well, that's how it is. And they occasionally, you do see conversations, legal action about, whether you can or can't take organs. But the Spanish just don't have that, because it's just, that's what we do. It's part of being Spanish, if you like. And again, you know, I don't know, I wouldn't want to speculate on how revolutions and how kind of, you know, nations coming together, how that plays out with organ donation in the longer term. But, you know, as I said, I'm not surprised that Australians are not enormously keen about being told what to do. But also, we're also not so stubborn as to not take the best advice and make it our own. And I think, as I said, Donate Life is doing its best to do that. And Lucinda and Helen, you know, have done a remarkable job. I mean, I was the longest serving step medical director ever. And I saw 3 or 4 different heads of Donate Life, and I always felt a bit uncomfortable. We kept moving the goalpost. But Lucinda, they're not here, so you know, there's nothing in me to say it. But Helen and Lucinda are a remarkable partnership, and Lucinda is a remarkable leader, and Helen has been fantastic. And again, you know, from Victoria, it's not always easy conversation to say, "Hey, look what we do in Victoria," because that would have has WA intensivists go, "Yeah, well, you know, thanks," but. And you know, and as you probably know, you probably recognise the north and south of the river. We don't do it like that. Well, we're not interested in what you say. And interesting, you know, Fiona Stanley, as I said, is an interesting hybrid because people from both have come, and actually a new group. I'm aware that Donate Life sits much more comfortably in that new order. And again, that's not to criticise; it's just to acknowledge that that's human beings. But I think, as I said, for the community, we need to make sure we do better.
Thank you for that. Now I would like to move to a few questions based on your submission. And you stated that OTA's data reveals an alarming failure by critical care services to collaborate and liaise closely with Donate Life staff. Can you please provide a few examples of that observation?
Yeah, for example, so although Donate Life staff are able to move in the intensive care unit and are aware of patients, we would not be involved unless invited. And we would not look as to whether someone was even on the register unless invited.
By staff members in the ICU?
Yeah, because we are separate to them. It is their unit. And it's very important, of course, for families as well. You know, it's important to know that there's no conversation about donation until the conversation about futility and inevitable death has been had. It's not a thing. And there are occasions when you know, Donate Life staff, they know what's going on, but they, as I said, they don't take a view. But I'm aware of situations when, despite there being grounds to refer to us, in other words, there was an inevitable passing of a patient, we were not asked, not invited. And I'm even aware of situations where because once the patient has passed away, obviously organ donation is not possible, but tissue donation is possible. And I'm aware of situations where once the patient's passed away, we can then approach the relatives about tissues because the patient's died, so they're not under the care of the intensive care unit. And we then discover that the patient was on the organ donor register. Now, of course, that's a very difficult conversation to have with families when you say, look, we wondered if we could take the cornea or skin or bone and those, you know, heart valves, for them to say, well, they're on the register, and we say, well, obviously, you know, that's why we're asking. And they say, well, no one has asked us that before. Now, again, don't get me wrong, no one has deliberately created that really unfortunate, but it's a great example of how the more you raise the awareness about donation, the more you have to have that conversation. You know, as I'm sure you've heard, it's not about asking yes or no. It's about having a conversation and saying, look, this is the clinical situation. It's possible that they might become a donor. It's not a definite, but But if you don't have that conversation, and don't get me wrong, again, that's almost exclusively from clinicians about protecting relatives, about, not wanting to upset them some more. But again, Donate Life Canberra have done the studies that show that people are not additionally traumatised by the conversation. Of course, I mean, as I said, my colleague says, it's never a good time to ask because it's always associated with a tragedy. But doctors, in my eyes, are compelled to share the outcome, the perceived outcome with the transplant specialists, the donation specialists, and thereby have them involved in the conversation if it becomes relevant. In other words, if the patient is a suitable candidate. And I think by doing that, you avoid those really unfortunate, and don't get me wrong, rare situations where you discover that the patient, and I've had people say to me, why weren't we asked? And I figured, that's a good question. Whereas I spent my time trying to open other units that could do donation, because I figured that if we make a big thing about organ donation, and then say, for example, Albany or Port Hedland, if we say, oh, but by the way, we don't do it here, I figured that the community would say, well, I thought you said it was important. Well, yeah, it is, but you don't do it here. Well, no. And if the answer is because we just don't, I didn't think that was okay. If practically speaking, if outcome speaking, it's currently not possible, then I can say that to relatives. I can say, look, we looked into it, but it's not. But what I can't do is explain to a family, why didn't they ask us? Because it's not my patient. It's not for me to say. And, as I said, now having not been a doctor for 4 years after my accident, I'm kind of in a privileged and unusual position where I can say, I think from a relative's point of view, that's a good question. And again, I know that the motivations are probably largely around, oh, well, they were terribly upset and they were terribly wrong. Of course they were. Of course they were. I mean, I remember, one lady whose daughters both had lost their lives. And she said to me, look, it's no consolation that they were donors. And she would speak for us. She said, if I got the chance, I would have my daughters back, but I couldn't. And so I'm glad I was asked. So, well, I think intensivist specialists in that area are, again, hugely specialised, super skilled and wonderful people. To a degree, they're protecting. Look, and if I were honest, they may even be slightly protecting themselves in the sense that no one wants to. I don't want to upset you with another question when I've already. I don't want to upset you by bringing someone in the room that you've never met. I don't want to upset you by saying, look, something wonderful can happen. We'd have to fly you 2,500 kilometres and introduce you to, And similarly, I don't want to tell you that, look, it's going to be another 2 days before we facilitate this. So can you just hang on? Because people are exhausted and at the end of their tether. So, as I said, often clinicians' argument is, well, it's my decision whether I ask or not. And what I would say is we need to get to a point where it's not a question. It's not like the Spanish model. That's the Spanish model. It's not a question. It's just a normal part of what we do in terms of end-of-life care. We know that best practice is to ask everybody to let everybody know about the information around it and let them make a decision. And I think there's no room for sort of, I'm the expert, so I'll decide. There's no room for that. And I understand the motivation behind it. I don't want to see people burst into tears, and even more than they already are. They've only just dried them from, sitting with a relative and holding their hand and wishing that things were different. And in some ways, that's why Donate Life staff are good. They come in and they're amazing. They practice this all the time. They're having that conversation. I don't really know how, because it's a tremendously difficult job. It really is. That's their expertise, and it's not to say that doctors can't do it or shouldn't do it. We train them as well. But sometimes, as I said, as a critical care consultant, I might have 30 patients. And with the greatest will in the world, I don't have 3 hours. And I don't mean I don't want 3 hours to spend with the patient. If I could, I'd sit with their relatives and be facetious and tell jokes and try and ease the pain all day. But that just isn't, again, you know, we all know that in our professional lives. Like a counsellor, it just isn't like that. You don't get to give a bit of yourself to everybody. And I think intensivists are sufficiently busy and sufficiently smart that in the future we will see them, it will become a normal part. And I think, you know, if you try to legislate for it, I suspect you would get more pushback. You know, I think, like, if you said opt out, I think, you know, again, never mind what the community would think, you could easily have a conversation around, as I said, about forcing people and things. Well, no one's ever forced anyone. But it's a very difficult one. And again, you know, the strength of Western Australian intensive care is they're remarkably independent and highly skilled in a quite isolated place. And those strengths are sometimes also one's weaknesses when you have to play cricket, share your ball with other people. And so that's a good and a bad thing. And as I said, I think Fiona Stanley demonstrates the times are changing. Maybe they're not changing as quickly as people like. And I think your point about opt-out, I think we probably will come to opt-out, but I wouldn't want it to be a controversial thing. I would want it to be a thing where people go, oh yeah, and you know, people don't want to talk about death. I mean, half of us haven't got wills, for goodness sake, never mind, you know, descriptions about what we want. So it's not that we're not up for it. I just don't want it to be talked about. And if you're not careful, you push me too hard, I might say, all right, well, do you know what? No. Which we know is not the thing that people want. So, you know, I think WA has done a remarkable job in expanding our catchment area, increasing our numbers, and times are changing. And I think they will continue to change. You know, Rockingham, where I was, I noticed a couple of years ago, did 5 transplants. You know, the idea that Rockingham, as an intensive care unit, would do 5 transplants is remarkable, retrievals. And of course, their community thereby become more engaged themselves because our local hospital does it. Okay, and you know, and Midland, look at Midland. I mean, Midland's head of department was one of my juniors at Rockingham. She's now gone there, taken the reins, and now they do retrieval. And it's not even impossible that we might have a roving unit who go to Port Hedland, who go to Kalgoorlie. I mean, I did a circle of the units when I was there, and I think, again, by enabling the community to be involved, you have them have a voice to say, it's okay. It's okay to ask me. In fact, why haven't you asked me? And that then, I think, eases the burden. And I'm sure doctors would say, well, it's not a burden, it's fine, but they're humane, wonderful, generous people, and no one wants to upset someone with a question that you feel like you shouldn't ask. But our Donate Life's evidence is you should and you must ask.
Now, Bruce, you talked about the challenges that in this space,
yes,
with ICU staff and Donate Life,
yeah,
staff. Was or is there a policy in place encouraging ICU staff members talking to family members when one of their relative is at the end of their...
Absolutely there is, and actually the policy best practice would be to involve Donate Life in that.
Okay.
There's no doubt about that is a national policy, and again, I'm sure Helen will tell you, you know, under her leadership, Victoria does that.
So it's a guideline rather
than
there
you go, you
requirement.
See. This is the thing, isn't it, is policies and guidelines. Again, if you push highly competent people around, they will tell you, well, actually, in the dead of night, in the early morning, I'll be doing it and you'll be in bed. So let's try and be too prescriptive. And again, I think that's why I think the ICU community as a whole in Australia, except probably the data suggests that having Donate Life in the room is a good thing. Okay. And I think, as I said, the more you embed staff in the units, the more that you become a normal part of what you do, then I think, you know, the wheel will go. And as I said, I think Fiona Stanley has illustrated that when you mix people up and drop them in together, actually a whole new can-do kind of culture emerges. So, yeah.
Do you have any views on living donors? How we can encourage more donors in that?
I think, as I said, on the kidney unit, a long while back, we saw a lot more living donors. I think it's kind of, if I were to make any comment, it would be to that that's a whole different ball game.
Okay.
I think the living donor issue, obviously, again, clinically, it's a very much more difficult thing because you've then got the responsibility of the donor's outcome, and that in itself is a big thing. The last thing you want is for a donor to struggle, and certainly being a living donor is a remarkable thing. And I think this system where we're able to take organs between one another such that they all end up with one, even though they didn't originally match, those things are remarkable. And I think it confuses the issue. I think, again, awareness, I think perhaps, again, I would, in amongst everything I've said, what I haven't said is I do believe that the single most neglected group in all this is primary care, because primary care GPs see patients all the time. They see patients all the time. They know about them. And we almost exclusively exclude general practice from these sharing information, awareness, conversations with their patients. And actually, I think that's a real shame because, ironically, and I remember another example, we have to go to the general practitioner if we want to do a transplant and ask them, are you aware of any problems? And sign a form. I remember a couple of GPs being very angry with me to say, have you any idea how busy we are? Have you any idea how much it will take for me to fill a form in that you will give me no money for, no recognition for, which isn't really the point, but I think the point is that you don't value me even enough to sort of acknowledge that what I'm doing for you is over and above my already onerous work. And again, very few people know someone who's had an organ transplant. It's one of the reasons why it's quite difficult to do, is because unless you've been touched by the topic, you go, well, I don't know. Whereas general practitioners have contact with their patients all the time. They have conversations with them all the time about all sorts of things. We're talking about, obesity and diabetes and blood pressure and heart disease. When you're sitting in, let's be honest, unless you've got a super duper general practice, you sit in the waiting room for a decent while. And if we agree that it only takes 5 minutes to register, and most people are pretty cool about it, then there's an opportunity. But again, you can't ask general practitioners to do that important work unless you put them in front and centre of your conversations. Helen's a highly qualified intensive care specialist. Lucinda's a high-powered Canberra, leader. And GPs go, well, no one even talked to us. So again, I think there is an opportunity. And again, I know that general practitioners are going to go, okay, do you mind not volunteering us for another onerous role? But I think with a little bit of recognition that, look, you doing I actually tried to start giving them $50. And I know that seems ridiculous, but at least it's a recognition that what you're doing for us is important. Because let's be honest, if you literally just expect people to do it, you don't acknowledge that it's a big thing for them. We need it straight away. If we think someone's going to be a donor, we need to know straight away how they've got a history of things like melanoma, things that would automatically preclude donation. Often the general practitioner is the only one who knows that.
Yep.
And again, if you just sort of go, well, could just interrupt you during your clinic. No, you can't actually, because I've got 30 people. And of course, particularly if we live rurally, I'm the only one. And you just expect me to roll my notes out and just have a look. And again, a family would say, well, it's very important. And the general practitioner would say, it is. And so are all the other things that I'm doing. And again, I know that the bigger debate is about general practice and about putting it at the forefront. It's not the glamorous thing. It's not the intensive care unit. And yet, if we agree that organ donation is a community venture, primary care is called primary care because they are the front line. They are the ones who can have conversations. They are the ones who could hold little conversations in their general practice because, as I said, people want to be part of something.
Do we not now move to digital records where lots of people can access those? Like, did we have to, ironically, opt out of that? Is that a thing? Or,
Well, we have.
or
Well,
do we still need to go back to the GP every time. Is there a way to?
well, okay. So I suspect that without consent, you certainly do. I mean, there are things like there is a register for things like melanoma, so we do have access to that. But again, you know, when our specialists go to see a body, someone who's deceased or is going to be potentially a donor, we actually do a visual inspection because, as you know, melanoma particularly is an absolute no-no, and it's very common in WA. It's very common in Australia, relatively common, and it's an absolute no-no. If you transplant organs from someone who even has ever any history, you can light a fire with the immunosuppression. So when you suppress people's immune systems, it releases melanoma, and melanoma is a terrible thing. So if there's ever any even question about what was it that somebody removed, then we say no. We say no because you have to protect the recipients. So again, the general practice is so important. As you said about electronic records, most people do. I mean, our hospitals try to go electronic, but that's kind of manifested itself as sort of writing on sheets of paper and then scanning them and put them in the notes, which and again, general practitioners, many I think are caught between digital and paper, and certainly, you know, my experience of being in the UK and somebody having another medical condition that when he changed practitioners got lost in the post kind of thing and a bad outcome. So I think you're right. Sure, in the future, as you said, you could literally have an automatic. That's a no, but we're not there yet. And so all that
Might be something that we think about in our recommendations and report.
look, and I think, you know, the digitalisation of medical records is incredibly complex. As you know, the UK tried and spectacularly spent billions of dollars trying to make everybody's systems work together, and that didn't go so well for them. So I wouldn't advocate that. But again, I think, and again, rather like the acceptance that that's the best way to go, is everybody has to jump, don't they? You have to find the lowest denominator, the slowest speed that anybody dares to move forward and say, is everybody with this? I think any kind of mandating of... Yeah, and again, as I said, that's me with my ex-Donate Life head on saying let's not upset anybody because you have to have everybody on side. Now, you know, as politicians, I suspect you have to deal with that every day. And as I said, that was one of the lessons I learned, was that however passionate I felt about it, you had to be smart, strategic, you know, and speak to what people wanted to hear. And you look, you know, we already know that organ donation, kidney transplant saves $100,000 per year. So even if you are not bothered too much about organ donation, if you're a finance person, it still makes sense.
Yeah.
So it has to speak to something for everybody, you know, I think, and that's an important thing about this, is that it sounds cynical, but it has to speak to the bigger picture, which is that lots of parts of health, I mean, we're over at 25% of GDP spending on health, or we could spend 50, but the fact is we have to take it away from somewhere else. So all these conversations we have about what organ donation might do, they're in the context of, we could have a 747 and fly people around Australia. Of course we could. But we don't. I mean, but occasionally, you know, I remember we once sent a liver to New Zealand from WA. And the relative was astonished that we would do that. And we said, well, it's because what you've agreed to donate is remarkably precious, and we will hire a jet and we will fly it, because that's how much it means for the person who will receive it.
Thank you very much, Bruce, for that. We sincerely appreciate your time, and as with the last hearing, we have gone over time, and so our appreciation again.
Well, thank you.
if there are no final questions from the committee, I would like to thank you for attending today, and please end the broadcast.